So, Mr. Chairman, dear colleagues, good morning. We are now trying to start from the first slide, not from the half of the presentation. And we are speaking in this session also about vasculitis, because sometimes vasculitis presents some problem in diagnosis. And when we look at a picture like this, we see crusting, rhinitis, we see ulcer, and we may have a bigger problem in the diagnosis. And if you look at the diagnosis, we see in the first two upper panel that they are GPA. Then there is a CMDL, that is a cocaine-induced midline destructive lesions, sarcoidosis, IgG4, and again, CMDL. And when we look at the differential diagnosis, we enter in a huge complex of different diseases that count lymphomas, infectious diseases, non-granulomatous immune disease, toxic exposure, and the granulomatous disease. Among the granulomatous disease, we have sometimes more difficulties in making a differential diagnosis between the granulomatous with cholangitis, what was called Wegener granulomatosis, and the cocaine-induced midline destructive lesions, even if also the GPA, the Church-Strauss syndrome, is considered an ANCA vasculitis. They are generally commonly caused by infection, characterized by multiple chronic inflammatory lesions which can affect all the body system and can present a bewildering array of symptoms. The nose and paranasal sinus may play a host to large range of systemic diseases. Epistaxis, nasal crusting, midline destructive lesions, nasal septum perforation, cartilage and bone reabsorption, nasal paranasal granuloma, and nasal deformity are not specific findings. So we start with the GPA, the granulomatous with cholangitis. We know that is a granulomatous systemic vasculitis of an origin involving the upper airways and kidneys. The prevalence is 3 cases on 100, 90% of patients are Caucasian, the mean age 55%, sinusal tract and nasopharynx are involved in 90% of patients. The pathogenesis is unknown. We know that there are still valid the classification criteria of the American College of Rheumatology, and the presence of 2 or more criteria yields to a sensitivity of 88.2% and a specificity of 92%. It's very important in this group of disease the consideration of the CIANCA. We know that we have to find with the histopathology findings necrosis, vasculitis, granulomatous inflammation, and then the CIANCA anti-PR3 in the systemic GPA are 95% pathognomonic, while in the localized form only in the 50% of cases. The ENT in the GPA is very important because the sinonasal tract is very often involved. And you see that the nasal tract is between, according to different series, is involved between 60 and 90%, the ear between 20 and 70%, larynx between 5 and 20, ear and orbit between 6 and 50%, oral cavity and salivary glands are rare. With the endoscopic findings, we can see crusting with mucosal hemorrhages, cartilage and bone reabsorption, and sometimes we see a nasal deformity. The nasal deformity nowadays is more rare because we are able to arrive priorly to the proper diagnosis. With the imaging findings, we can see inflammatory changes of the mucosa, destructive changes, receptor cartilage and adhesion structures and the sinus wall, and sometimes we have presence of masses and changing on CT and MR. Also external ear may be involved, and sometimes also middle ear with otitis media with effusion. Sometimes it takes 1 year, 1.5 years to arrive to a diagnosis of GPA. And it's very important to remember that nearly 50% of the pediatric and adolescent patients who present with GPA can be affected of laryngeal disease. Sometimes in GPA, the laryngeal the larynx is the only site where the GPA is present. And they are very important also the ocular localization with visual loss, secondary to optic neuropathy, proptosis, scleritis, uveitis, and you see that in this patient we are looking from the eyes inside the nose because there was a complete destruction of the lateral nasal wall. Is very diffuse also the oral. When the oral cavity is involved, there is this kind of strawberry gingivitis that is very typical in GPA. Regarding palate perforation, we will see the next slide, and also salivary glands may be involved. Palate perforation in GPA. There are only 5 cases published in the literature regarding palate perforation and GPA, and I don't really believe that they were GPA. And if you go and you look in the literature, in the first there are scarce information. The Imoli et al. Is an unpublished case mentioned in a letter to editor, Shasha et al. In unclear findings, Mangano and Bryant diagnosis by exclusion, and the Rice et al. Diagnosis based on a clinical examination. So the 5 cases in the literature are not really consistent with the GPA. Our role is very important because sometimes we can see if there is a relapse before the clinical examination. And you see that in these images, it's quite clear where we have relapse and where we have not, because where we have the ulcer with this crusting is easier that the patient may develop a recurrence. We have developed a classification, use the nerve band imaging, and there are some patterns that you can identify in this kind of patient. And you see that you may have some vascular island, some wet pattern, a rosary beam pattern, hypertrophic vessel, and a tree-like vasculature that are present only in GPA patient. And what is very difficult is sometimes the differential diagnosis between the GPA patient and the patient that are using cocaine. Is a disease that mimics a systemic disease with positive antineutrophil cytoplasmatic antibodies, and there are about 170 cases described in the English literature, and you see that destruction is a centrifugal destruction. We have studied for several years this kind of disease, and we were able to identify a precise pattern of this patient. When we look generally the CMDL patient compared to the GPA in our series, it was more serious and there was more destruction in cocaine patient when in the GPA, and the destruction is quite similar to what we found in the literature compared to our series. And you can see patient with a destruction of the nasal bone, like this lady that in 1996 had only a destruction of the nasal bone, and in 4 years she developed a complete destruction of the nasal bone and of the palate. And if you look the course of this patient in 4 years with the destruction of the hard palate, and if you look at the MAR in the upper right panel of inferior, middle, and superior turbinate and of the hard palate, and 4 years later that she developed a huge a skull base encephalocele, anterior skull base encephalocele, and you see that the palate is not anymore there, and it is not more there any of the nasal sinuses. Then we can see other example of destruction of the palate. You see in the upper panel 2 destruction of the hard palate, in the lower panel the same images taken with a 30-degree optic through the nose. Another example of a huge perforation. In the center upper panel, you see from the nose with a 30-degree optic that the palate has already gone, and there is also nasocutaneous fistulas, and the same you can see at the MAR with destruction on inferior, middle, superior turbinates and the hole in the hard palate. You see, when you have patient with a destruction of the columella like this, generally you think is a lymphoma, and the problem is becoming very big when the patient is completely denying the use of cocaine, because you start thinking to different possibilities in the diagnosis. These are other examples of destruction of the nasal bone and with the nasocutaneous fistula. And you see this is one of the last patients we see with a complete destruction of the palate. You see that there are bone completely exposed, there is infection, there is crusting, and this is the picture of a lymphoma, not of a patient that is using cocaine. And the problem in this patient, and that sometimes they develop also ANCA positivity. And as we saw before with the GPI patient, the positivity to CANCA is a pathognomonic finding for GPA. So when you have a patient with destruction and GPA and the ANCA positive, you think to GPA generally if the patient is denying the use of cocaine. And when you look at the histopathologic features, among the vascular changes, there was no difference in our series between the CMDL patient and GPA patient. And the only difference was that the GPA patient had extravascular changes that the CMDL patient have not. So, regarding pathogenesis, every time when you speak with a colleague, they speak about vasoconstriction, irritant effects of adulterant, traumatic effect, recurrent nasal infection, epistaxis, crusting, but this is what happened in all the patients. And with millions of people using cocaine, there are only hundreds of patients developing such important lesions. And we were able to demonstrate that there is apoptosis that is involved. And with the research, now we have discovered that there is probably a genetic difference in this kind of group. So we were able to demonstrate that only the patient with cocaine lesion had positively in apoptosis. The apoptosis is strongly activated, but only in CMDL, not in GPA, polyposis, and in healthy patient. And so, of sure, apoptosis have a role in the development of this kind of lesion, and we will demonstrate in the next year, I think, because we have already the data, that there is a genetic variation in this patient. So, is always very important, the first contact, the biopsy, the exclusion of other possible lesion, because once we had a problem that has a GPA, and as he was not breathing very well, some friends told him, try to use cocaine. So he was a GPA patient using cocaine, and that was quite disturbing us in the diagnosis. And of course, the follow-up is very important, and it's very important to have a timing for surgery, because we know that between 75 and 90% relapse within 1 year to use cocaine. So according to us, we have to make a monthly follow-up with nasal endoscopy, urine analysis, and after 12 months, you have two possibilities. If he has stopped using cocaine, you can go on with prosthesis or surgery. You can go on with surgery. But if the patient is still going on with abuse, you can only make medical therapy and prosthesis. And the follow-up restarts again if patient relapses in drug abuse. If 6 months is without cocaine, he's make only one, he starts again from zero the follow-up. When you use prosthesis, you can work with your dentist and develop such a prosthesis that has a very good functional result. And that is a prosthesis that is used for the nose in this young guy with destruction of the columella, and represent the history of what should have a patient that is using cocaine. He stopped using cocaine for 2 years, and while he was stopping, he used this prosthesis for the columella, and after 2 years, when we were sure that he has stopped, we went on with the surgery. So in CMDL, it's very important understanding the patient and the experience. So understanding the patient reasoning and motivation to undergo surgery and their comment to living cocaine-free is crucial to long-term success of surgery. And patients who continue to abuse cocaine are not suitable candidates for this type of surgery, as further abuse will inevitably destroy the reconstructive frame. So it's very important to remember that when you make reconstruction on cocaine patient, you have a bigger problem than the reconstruction with oncologic patient. Because when you make a reconstruction in oncologic patient, the margin of the tissues are healthy. But when you work with the cocaine patient, you have an alteration in the vascularity, so it's more difficult to have reconstruction in this patient. So, as a final remarks, the diagnostic workup starts every time with nasal endoscopy, histology, so you can make a differential diagnosis with other problems like lymphoma, infection, cholesterol granulomas, Langerhans cell. And if you find giant cell macroscopic foci of deep located necrosis, you know you have a GPA. If you found some particularly at the MBI, is another signs of GPA, because we need to find several instrumentation and new things to make diagnosis with GPA, because we are not working between black and white, we are always working in gray. So whatever help us is welcome. And sometimes happen that this is not diagnostic and you go for the ANCA test, and the ANCA test may help you if you have HNE ANCA for CMDL and the PR3 ANCA for GPA. And it's very important that the diagnostic suspicious, the follow-up, the topical treatment allow for correct, timely, chronic management and preventing reacutizations and avoiding. So, it takes little to make the difference. Thank you very much.